Most of you will recall that STPs in England had a bit of a, shall we say, challenging start, referred to widely as secret Tory plans, and certainly the word secret was very prominent in any media reports about what STPs were actually all about. So a difficult start for leaders in Kent and Medway to make any progress on planning for local people. So one of the most important things for today is to get behind some of that rhetoric and to show you what work has been being done in Kent and Medway on behalf of the population as a whole, and hope you see that actually there's been some really hard work focused on some important priorities that are about improving the health and care of our whole population.
There are 1.8 million people at the moment in Kent and Medway and it's going to get bigger, and they are depending on us and you, the people in this room. There is nobody else out there who's going to do this. We have a responsibility to do this and actually make the population in Kent and Medway get the best possible health care that we can within the resources we've got.
I have to confess that in Medway, I've actually added a dog to that logo. And the reason is not just because I happen to be a big dog lover myself and I've got dogs, but actually what's important to Dorothy may less be about what's the matter with her physically, but what is important to her, what matters to her as an individual. So actually for lots of people, you know, that their pets, their family, all of those things are really, really important to them. And if we ask people what their aims were, it might not be some of the things that we think of. It might be, I want to go to the lunch club so I can see my friends because that's part of me being part of my community, or I want to go to my allotment. But what we do know is that over 90% of care is provided in primary care. And we also know that one of the big drivers that drives people into health and social care is loneliness. And that is not something which is cured by pills and operations. And so we can't have a model going forwards that doesn't acknowledge the bigger social context in which people live their lives and their importance of that, and for us to provide a very different offer.
The most important of these concentric circles is the one in the middle, the very centre, which is about a person, not a patient, about a person. So what we looked to do was to build out from the needs of the person and the patient, and an absolutely pivotal building block around this is what we call in Kent and Medway local care, a system that wraps around the patient to make sure that if they fall ill, we pick them up, and as much as we possibly can, we keep them out of big, expensive acute hospitals.
We need to keep our eye on the fact that this is all about patients. This is about saving lives, it's about better care, it's about better quality of care and care closer to home. We started at the beginning looking at acute care, and arguably that was not the right place to start. We started a lot of discussion around how we were going to configure our three acute hospitals. If I were to do it again, I'd start absolutely in the community, because fundamentally some of the assumptions that we made around how we were going to reconfigure our acute hospitals was not possible without having a really good underpinning community strategy.
The clinical board has actually undergone a slight transformation in that we are now the clinical and professional board, recognising that clinical seemed to indicate that it was just purely about health. And there are many, many professionals who our patients and our communities depend on, who are not necessarily doctors, nurses, physios, and this is very much to represent the professionals who work in social care. Each of the areas that are identified as our priorities will consider prevention, well-being, holistic care, as well as being patient-centred and co-designed. There will be a coherent pan-regional clinical strategy with consistent care and quality of care at the heart of it. And I think we have agreed that pan Kent and Medway, because there will obviously be things that need to be delivered locally and decided on locally, but there are some where we do need to take a view across the whole of Kent and Medway. And that will be on prevention, mental health, cancer, and children and young people services, all of which are areas where at the moment Kent is not doing as well as it should. Stroke and vascular have been highlighted in pink, and these are areas where for stroke there is no unit in Kent that meets more than 2/3 of the national standards, and therefore our outcomes for stroke are not as good as they should be. And so we have concentrated this year on the stroke service, and now are about to go to consultation in the spring about those services.
If you think about one of the major drivers in the 5-year forward view for mental health, it's about stopping out of area placements. Clearly, moving people around the country, particularly just because you don't have capacity locally, is not ideal. It takes them away from their clinical teams. Awful to be taken away from your family when you're acutely unwell, and it slows recovery, so people end up staying longer. As bad as that is the financial cost of it, and if you think back just a year ago in this county, we in KMPT had 76 patients in private beds out of county, some as far-flung as Manchester and Hull. Even if those beds had been free, even if they were free, it would have been all sorts of wrong. Those poor patients, miles from families, families not able to visit, clinical teams not able to follow them up, and the quality of care sometimes, I have to say, poor. The cost of that per month to the system as a whole was over £1 million a month. We've sorted it out through clinical leadership and management, unlocking the talent and removing the barriers. We've sorted it out. So as I stand here today, none of our patients go to private beds. They're all looked after in KMPT beds. I'm sharing that because the driver for STPs and sustainable transformation is about two things, I believe. It's about driving up quality and ironing out the inequalities that we've heard about through the day. It's also about making sure that the books balance. And that's a really good example of where we've done the two things together. And when I talk to patients now and families and to staff, the relief that is present, because they know that if they need to come into hospital, they can come into a KMP bed locally, and staff know that there's the capacity there to admit someone when they need to come in. Clinical leadership unlocked all of it, and I think we come back to that throughout all the presentations today.
People live in a family, they live in a street, they live in a community, they have interests. We need to find out, I think Caroline was referring to it earlier, we need to find out what matters to them, not just what is the matter with them. So within social care, we are trying to flex our business model and understand how can we find out what makes somebody tick, what makes them stay well, what they have in terms of their own personal assets or their local assets that can enable them to do the things they want to do, be who they want to be, and stay well for longer.
If you're in a crisis, what do you need us to do to stabilise it? If we can help you to go back to having ordinary support near to home, how can we find that for you? And if those two things haven't worked for you, what do we need to do with you in terms of our ongoing long-term support? Participation and partnerships will be very important, and we've heard a lot about the partnerships that we need to develop today. As a twin hatter responsible for children and adult services, I suppose I want to say a bit about some of the less obvious partnerships. We have nearly 60,000 children in Medway. I work a lot with leaders in education, and they are really interested in the change that's happening in health and care. Because actually what we do in our systems impacts on the learning outcomes for children in schools every day. So it's important as we move forward that we really focus on hearing some of those harder to reach voices.
It amazed me when we started this work that we actually have 350 voluntary sector organisations on our patch. If you'd have asked me, I thought it was about a tenth of that. Now, as a GP, I cannot possibly remember 350 organisations, let alone have a conversation around them. But I can remember one phone number, and so if it's Red Zebra, then I can refer them for an assessment, and they can decide which one or more of those organisations can actually help that patient. We co-produced an app called Waitless. Who hasn't got Waitless? Right, you're not allowed to leave tonight until you've uploaded it onto your smartphone. This is an app which we developed with our patient groups and also with Transforming Systems. It shows all the minor injury units and A&Es in East Kent, so it's a present to the whole of East Kent, and it geolocates you. It's telling me I'm here in Maidstone, and then it ranks them in terms of waiting time. So the fastest one currently has one person waiting. At this moment, unfortunately in Margate, there are 52 people waiting. and in Ashford there are 60. So if you've got a minor injury as opposed to a major one, this is a way of you finding out where to go, giving you a combined travel time and waiting time in the department.
As Ruth mentioned, we know that STP started off their life in a pretty complex environment and had to make fast progress in coming together and developing system-level plans. It hasn't been an easy process, but looking back, it was an impressive thing to have done. And arguably, it's the P in partnership that's been just as, if not more important than the P in plan. An ACS is an evolved version of an STP, or part of an STP, in which organisations go beyond creating systems and take on collective responsibility for managing performance, living within a system-level budget, integrating services and applying valid population health management approaches. We're asking STPs and ACSs to think and act like systems rather than individual organisations, so we accept that the way in which NHS England and NHS Improvement need to work together should change to reflect this too.
It seems to us the STPs who fully got their GPs, local authorities, CCGs, hospitals, community and mental health providers, and I would also actually add the third sector, fully involved in their plans are the places that seem to us to be really motoring. Secondly, that there's an unequivocal willingness to prioritise the needs of patients and the system at the expense of the individual institution, which can be really, really difficult given those governance structures, given the culture, given the way that things work. Thirdly, a really ruthless focus on a small number of practical priorities. And what I'm saying is, if you actually, in my view, and again, I hope I'm not being too rude here to our colleagues at NHS England, but if you followed every single thing that the SDP was asked to do, you'd be trying to boil the ocean. So our view is that the SDPs that are succeeding are the ones that are really saying, okay, these are the 3 or 4 or 5 things that really matter to us. They really matter to our population. That's what we're going to really drive on. And then what people then do, fourth point, is they're driving rapid on-the-ground practical improvements in the chosen priority areas. They're not just trying to build a grand plan in those areas. They're actually saying, let's get on, let's do some stuff, let's build confidence that actually this is all going to work. Let's do some practical things quickly to make some changes. And the final thing is, it's actually, for me, it's about pragmatism meets continuous improvement. And what I mean by that is, let's just get on and try some new stuff. And there are plenty of places where it hasn't really worked particularly well, but let's just learn the lessons of that and then basically do something new and improved based on that, the lessons that you've learned from that initial bit. But a real focus in those last 2 points about actually not just focusing on trying to do the grand plan, but actually getting on with some stuff, making things different, changing care outcomes, and then effectively learning the lessons from that and then carrying on to continuously improve the changes that you've made.
What are the most important things that people want to hear addressed in this meeting? The thing that consistently came back was about workforce. You know, don't tell us all about all these fantastic ideas and these fantastic plans if we don't have the people to deliver them.
One of the things that we have noticed, and I'm sure many of you sitting around the room, is that we have had for a long time a very significant focus on roles and supply. And we look at organisations, we look at professions, we look at roles, and we don't actually think necessarily as strongly and in as focused a way on our existing workforce. So what we're saying is that we need to shift the balance from supply. It's not saying that we don't need more, but that we need to do far more with what we've already got and how we can actually connect the workforce that we've got around us. And that actually means about looking way beyond the traditional boundaries that we currently look at when we think about workforce. I've heard it actually in some of the sessions that I've sat in on around the patient being part of our workforce. And actually thinking about social care, health care, people in the local community, whether they're carers or volunteers, and actually starting to think, how can we get far more out of the people that we have working with us? So I think people get very anxious about creating a rather generic workforce. So everybody losing their specialism and actually focusing on doing everything, but not perhaps actually really focusing on the things that they can do very well. So the really important thing about bringing these teams together is that you don't do that. You actually focus on keeping that creative tension going, valuing the differences, allowing people to share their learning and experiences and to build their capability and knowledge through education networks, bringing people together to learn from their mistakes, to learn from each other, to learn how things can be done. And leadership that allows them to innovate, take decisions and make and do things in a different way.
Unfortunately, the NHS often suffers with the wrong end of the telescope perspective, and it starts with the service, with the disease rather than the person. Obviously, that's not the case with this STP, as we've heard today, but that is a tendency that we tend to gravitate to the wrong end of the telescope. So when it comes to population health management and segmentation, whilst risk is part of it, and clearly people will have conditions and they'll be in receipt of services, that's not the place to start. Don't start with the disease or the service, start with the whole person. So people are not asthmatics or diabetics, we're not defined by the conditions that we have. We are a person who happens to have a disability or a disease or a condition or a need.
I think one of the key things for us in Thanet is that it's been organically grown. The clinicians, frontline staff, the patients have very much shaped how this looks. So we've done the estimate, we've listened and continually listened to what our patients are saying around what are their needs. And the staff have been able to lead that change as well. And if you talk to particularly some of our community nursing colleagues now that are part of a nursing team focused on competencies rather than, you know, numbers of staff that we've got, for them, how they work and how they feel about their roles is significantly changed. And one, you know, often sort of says about it's brought the joy back into her work. She feels valued as part of a team. And, you know, I don't think you can get much better than that in actually terms of retaining the workforce and continuing to grow it.
We feel really strongly that getting engagement right is about driving positive change, it's about driving improvement, and it's about doing that in concert with the communities that you're all trying to serve through the Kent and Medway STP. Good engagement is creative, and it doesn't forget that there is existing insight. The universe didn't start when NHS England invented STPs. There is lots of rich insight already there that can help both explain to people why you want to have these conversations and help drive the thinking about what the solutions should be. West Yorkshire and Harrogate STP has been a great example of that. There's been some really good joint working with the Health Watch up there, and they've been very creative in the use of digital technology, lots of social media activity.
My advice would be to engage again, and consultation and the time and effort needed to undertake really proper, valuable consultation cannot be underestimated. Be in there and help shape it to go forward. And you just need to keep going, because actually you only fail when you stop.
So I think, you know, together we are able to achieve great things. And I'm only 16 seconds over. Woohoo!